Good morning. I'm Lydia. I'm the spiritual health practitioner here. I'm going to look at you in the camera and also just the folks that are in the room. If it feels a little awkward, I'm kind of going back and forth. But it's nice to give a little bit of a talk today on what spiritual health is, and then specifically what does that look like at West Coast General and in our unique setting that is this hospital here, and then me as a person and what I bring to the team. So I'm excited to give the talk today. And I'm going to kind of go through the main areas of spiritual health, mostly with telling stories, because I think if you tell a story, people get what we do and who we are just as human beings in general, and then specifically when it comes to ways that we can care for our patients here. So when you think about just the word spiritual health, it's a really, in my opinion, really weird word, even just a weird title of a practice. And so I kind of pull back to a 30,000 foot view, first of all, and think of health as a table that has 4 legs. None of these, this one does have 4 legs, I guess. I was these guys only have 2 legs. But think of our health as having 4 legs. And you need all 4 legs there to be balanced, to be stabilized. And if any one of them goes amok, the table falls down. And those 4 legs, we think of the most obvious, the first table leg is our physical health. And in the hospital setting, that is such a no-brainer. I get that. You have all of your medical needs, and what makes you a human being has so much to do with have we preserved the heartbeat? And why are you coming in here for cancer treatments or whatever it is? All of the physical part of us makes us human. And the second table leg, for a long time, hospitals, healthcare only focused on the one table leg. Everything was just about preserving the heartbeat and what's your blood type and all of this stuff. And that's the majority, in all honesty, that's the majority of why people come into the hospitals. They need their physical health taken care of. Then there's this other table leg called our mental health. Along comes this guy named Freud, starting to study psychiatry and what does it mean for the life of the mind beyond the fact that we have a brain. What is the life of the mind? And 100 years ago, we didn't have psych wards. That was this weird anomaly. It was way out there. And now, 100 years later, we don't even use Freudian psychiatry because it's so out of date. But he totally changed our understanding of healthcare and brought in the life of the mind. That's the second table leg. And then the third table leg is our social life, who we interact with, what our socioeconomic status is, and how that actually affects our healthcare. And again, even if you think about it, this is a recent development. Even 20 years ago, 50 years ago, we didn't have social workers in hospital. That was an unheard of, unusual anomaly. And now, social workers are tons in the hospital saying this actually has a big thing to do with your health of can you even afford the medication for your diabetes? Do you need help to get onto disability? Are you going to be away for 3 months getting treatment and you're going to have obviously some social needs, or maybe you're not even housed. Social workers have come in to address that, also saying this is part of what it makes us human. And when one of these things, our physical, our mental, or our social health goes amok, the rest of the table falls over. And I want to suggest that the fourth table leg is our spiritual health. And has a lot to do with all these 3, but it's different from physical, mental, and social. Our spiritual health is what makes us have meaning in life. What do we attach our value to? How do we get our agency? What gives us a sense of purpose? What gives us a sense of a connection to the transcendent, if you want to put it that way? Or just basic meaning making. My life has meaning when I am with my family. My life has meaning when I feel like I have a purpose and I can be in community serving. And if that gets taken away or altered for a person, it drastically affects their sense of agency, their sense of being a human. And that can also drastically affect all those other table legs of their physical health, their mental health, and their social health. And so that's what spiritual health addresses and comes in. It has this large psychological lens. We have tons of training in psychology and mental health, but we aren't mental health specialists in the sense of I don't work with people that just have a diagnosis of, say, borderline or something like that. I work with people across any spectrum, and they may have mental health needs, they may have addiction needs, they may have social needs, may have just strict medical needs. whatever that need is, it's very likely that it is taking away some sense of what it means for them to be human and to have agency and to have a sense of worth and purpose in their life. So those are the 4 table legs. And now what I want to kind of go into next, before I talk about that, is maybe a little bit, I'll dispel a little bit of, I don't want to like get you thinking too much about it, because I think we've gone a long way from pulling it out, but dispel some of the myths of spiritual health. Way back, before we were regulated, before it was a professional practice, we used to have something called chaplains in hospital, and they did religious care. That's not what we are, and that's not even what we do. We do, however, have part of our training is a large part we do to study the global religions, because sometimes, not so much here in Port Alberni, but think of like a hospital in Surrey where you have a large Sikh population or a large Muslim population. A lot of certain populations, meaning is attached to a specific religious practice, and that really does bring them a sense of mooring, a sense of purpose. It can also cause sometimes catastrophic difficulties in their health care, and spiritual health can come in to help navigate those specifically, where we do understand their cultural and religious background and how that may be important to them and may affect their health. I'll speak to that a little later on when we get down to one of the things that we do, which is ethical dilemmas. And I'll give you some actual examples of where that can be a hard thing for somebody if they have a religious practice that is perhaps not aligning with their health goals. So we do, yes, have training and understanding the global religions and how that might help somebody. I rarely use it in my practice here, because I find most people in Port Alberni don't have a religious practice, they don't have a faith community. It's not particularly important to them. So even though it's training, it's kind of in the back burner for me here. But it's nice, I can pull it out and use it if I have somebody like a Jehovah's Witness that comes in, or Indigenous patients have a high value on spirituality and specific Indigenous spirituality. So understanding that and their frame of reference and what their cultural needs may be because of that become important. But if it ever does come up that you have somebody that is religious and they need some help even advocating and navigating the system because of certain needs that they have, I think maybe a practicing Muslim does need to go and pray 5 times a day facing Mecca. I can help facilitate that and say, okay, we need to advocate for that. How can this patient be able to practice that while they're still in hospital? Again, it doesn't come up very often in my practice here, but it is what I am trained in to do as one piece of the spiritual health puzzle. So when we think of spiritual health, just our training, we all have a master's. It can be in a few different streams. It can be specifically in spiritual health, which is what mine is, or psychology or counseling. And then after you do your master's, you need a year-long residency. It's 1,600 hours on the floor where you get your specific hospital training, and you take didactics. It's part of a postmaster's certification through the Canadian Association of Spiritual Care. So we have a lot of training. We have not only a master's degree, but we have a year residency program in hospital. This video might get old, but last year you guys might have remembered Matt. He was doing his internship with me. So that's what he was doing. He'd already finished his master's and he was getting his specific training in his residency to be able to practice in Canada. You need to do those 1,600 hours before you're qualified to come in and work in a hospital setting. So sure, you could put a shingle up and be a counselor, run your own private practice, that kind of thing. But to do specific hospital training, you need to come in and do that residency program, which focuses a lot on the specific things about the hospital: medicine, ethics, working with the interdisciplinary team, understanding how a hospital functions and works. So that's kind of what we do as far as being that 4th table leg, and then a little bit specifically about where we come from and what our training is. Now I want to talk about, at least for me in my practice, the 4 key areas of spiritual health, of what's my bread and butter. What do you mainly do? Who do you mainly see? And those 4 key areas are end-of-life care, emergency care, existential care, big word, I'll explain what it means specifically, and then ethical issues. And it's easy for me to remember because it's the 4 E's. So if you're like, oh, when do I refer for Lydia? If it's about end of life, emergency, ethical, or existential issues, those are the really broad stroke, easy ones to know this is something for spiritual health to come in and speak to. So let me tell you about each of those areas, some general ideas about it, or just some general information, and I'm going to tell you a story about each one to help it kind of put the pieces together. So end of life issues. We're under palliative end of life is where we're housed within Island Health, so it makes a lot of sense that we would do a lot of end of life care. I see every single palliative patient in hospital, especially if they're acute PAL. And the reason for that is that we help them in their death journey of what does it mean for them, thinking again, what are my personal values and beliefs, my sense of person, my sense of agency, and how does that affect me when I'm dying? For some people, that may mean a very specific leave-taking ritual. For others, it is anticipatory grief counseling of they've just received a terminal end-of-life diagnosis from Dr. Hudson and they're moving over to Dr. Woodley, and okay, I think that there's going to be some emotional things involved with that. It's not just okay, you're moving over to palliative. It's like, whoa, this is a major life change for me. There's going to be issues going on in my personal life. How do I tell my kids? I'm 36 years old and I wanted to have kids. How do I tell my family that I'm thinking about an assisted death with this? I just want to talk about this. How do I say goodbye? I do all of that anticipatory grief counseling with the patient themselves, and then I also do it with the family. So one specific example is if their PPS is 10%, I'm not going to give care to the patient, obviously. They're in their very final dying journey, but I'll come in and I'll see the family and help them move through that grief a little bit. I'll ask them questions like, tell me about this person that's in the bed that you're all coming to honor. And it's a beautiful way to get them talking. People don't know how to sit with the dying. They don't know what to do. They're like confused. Should I be mad at the nurse about giving them too much Haldol and Ativan or not? Or, it's like, no, we're just coming to sit together with your loved one, with your matriarch, your patriarch. Tell me some stories about them. How do you want to say goodbye? Sometimes there's reconciliation pieces involved with that. I'll often sit with patients at Ty Watson House at the hospice, and they'll say to me things like, I wish I had my kid's number so that I could phone them and ask their forgiveness, but I don't even know how to get a hold of them. And that's a very particular grief piece that they need to work through, the lack of their dying and their lack of being able to reconcile with the people that matter the most to them. And sometimes I am actually able to facilitate that reconciliation of, would you like to talk to your kids? They've actually said they would be open to that. I want to tell you about a story. Do I want to do 2 stories? Yeah. So those are some of those. I'll tell you 2 stories. When somebody's 10%, it's pretty, this is what I do. I come in and I support the family, help them sit with the patient, help them say goodbye, help them actually leave when the patient dies and say goodbye. Sometimes it's a much longer palliation. Right now I'm journeying with a lady, and I'll call her Jenny. And I met her on ICU when she was just diagnosed with pancreatic cancer. She had some sort of bleed. I don't know what was going on. I can't remember that. But I was giving some containment to her and her husband in the ICU. And Dr. Hudson had said, hey, you're going to be terminal. It's pancreatic cancer. We're going to move you down to an M2. Okay, she obviously has a ton to work through with that. And so I gave just some containment to them of their emotions and their grief and their anger in the ICU. And she recovered from the ICU, went to med-surg, and she's actually been long-term palliative. And she comes and sees me. She gets blood work once a week, and she comes in and sees me in my office about every other week. And she's doing well. She's doing palliative chemo. She knows she's dying, and she's working through so much with me in this long palliation. She's working through issues with her dad died of cancer, and she still has some unresolved grief around that. She also gets some triggered anxiety when she goes to Nanaimo for chemo because she remembers her dad and what it was like at end of life for him. So I do some practices with her to help her manage her feelings of anxiety while she's even driving to Nanaimo to get the chemo. I talk to her a lot about the legacy that she wants to leave with her 2 grandkids. I talk to her a lot about other family system issues with her 2 kids and saying goodbye to them and their ability or inability to engage with the fact that she's actually dying. I talk to her a lot about her husband, who's just there for her and is her rock, but she worries about him and who's going to take care of him and how is he going to work through his grief when I die? How do I talk to him about the fact that I'm dying? And she comes in, and sometimes we talk for 5 minutes. Most of the time we talk for 50 minutes about every other week, and that's a long-term palliation. Other examples of end-of-life care is I'll see perinatal losses. So that's a very unexpected loss, and it's a very private loss, but just being able to come in, and statistics back this up so much. If you're able to come in those first 48 hours and create a safe space for somebody to talk about their grief, about, in this case, this hope deferred, they wanted to have a baby and it didn't happen, to talk about what was the hardest experience for them, to talk about what it was like when the emergency doc said, hey, I'm sorry, but you've lost the baby. And I do that perinatal loss and bereavement support to them. I love it. That's I know it sounds weird to say I love it, but that is one of my favorite areas of giving spiritual health, is to moms when they have unexpected losses in their pregnancy. And then be able to just call them up. Sometimes if we built a connection, I'll call them up a month later and see, hey, how are you doing? Just that intimate stranger connecting in with them in a professional sense, where they can be their authentic self and not be like, well, I have to hold it together because you're my spouse, or you're my mom, or you're my friend, and I don't know if I can talk about this very intimate grief, but I can talk about it with a trained professional who gets me, who gives empathy, and I don't have to talk to you again afterwards. Like I'm good, or I can call you up afterwards. I love that role of spiritual health for that reason. Okay, so that was end of life. The other big one that I do is emergency situations. So I'll respond any code blue. Spiritual health jumps in with it like a dirty shirt, and we'll do containment for the family of sitting with them in that moment of a code blue going on, and being able to keep them calm, being that steady and sure person that's there with them, being able to translate what the doctor just said, because they're like way up here. They have no idea to even process what's going on, let alone what the doctor has just said in the update. And then just caring for that family and or that patient all the way through the process. So most of them end in death. So usually what happens is then I'll accompany the family to the bedside to be able to say goodbye to the loved one together, if that's what their wish is. Sometimes they don't know if they want to see their loved one who's just died. And I'll sit with them with being able to gauge their emotions and feelings, provide some dignity therapy of saying either option is okay. Follow what you're feeling. There's no right or wrong here. If you want to go and say goodbye to your husband, you can. They'll say, oh, I don't want my last memory to be of him rolling his eyes back right before he had his heart attack. And just hearing them be able to help them process those emotions and feelings. Again, statistically, it has showed so much that they're able to process their grief if there is a presence of a spiritual health practitioner there, even when the doctor comes in and says, I have the most grave news to give to you, your loved one died. Statistically, what we've seen is they actually have prone to have distrust in that medical person who told them the terrible news. But if there is somebody to bear witness to that news, they will establish a trusting relationship with that person who can then bridge back and forth between the doctor and the reality of what they're facing. So it's a beautiful thing. I love some doctors here make a habit of calling me in when they've got to deliver a critical illness diagnosis or a terminal illness diagnosis or even chronic, and saying like, it's going to be helpful if you can come, Lydia, because I don't have the emotional toolbox like you do. And then there's a lot more going on than just the table leg of medicine here. This is going to drastically impact their entire life. And that's what I can come in, not as their savior or I can do it all, but I can bear witness and explore with them how this one piece of their news is impacting their whole life, and then carry on. Whether that's like this one person that I see every 2 weeks for a long-term palliation, or maybe it's only one episodic meeting that I have with them, but it can just help them experience their emotions safely and to lessen the psychological impact of that trauma on them. I'll come to any sudden death, traumas in the ED, I'll come to, and again, if there's not family there, I can give direct support to the patient if that's medically appropriate, or follow up with them afterwards, and then journey through. It's another beautiful thing. It's similar to rehab. Spiritual health goes to every single unit. When that patient leaves the trauma floor and they come over to ICU, they're all of a sudden not being seen by Dr. Fine anymore. It's a whole new set of doctors. They got to meet Lambiot, they got to meet all these people. But hey, Lydia saw them in the ED, and Lydia sees them in the ICU. I'll see them on med-surg. I'll see patients or outpatients on rehab and come back to see me afterwards, because I can have that long-term continuity of care for them. As that familiar face, that trusted person of, I know what it was like for you in the ICU. I now know what it's like for you, and I can explore what that's like for you on the med-surg. And then this big word, existential, which means how we find meaning in life or how we don't find meaning in life. Doctors have coined it as existential pain. You'll see that documented of, I feel this patient is experiencing existential pain. They've lost their meaning in life. That doesn't necessarily mean that they need a med for an antidepressant or an anxiety. They may need to be seen by a shrink, but they've lost their ability to cope and they've lost their sense of agency. So I can come in with that to address those existential pain issues. And depending on how long I can see the patient, I may dive at that point into deeper psychological modalities of care and actually provide counseling to them. But it's appropriate. Are they medically stable enough to dive into some of these deep things, or am I containing with them and helping them come into the center, come into the present? I always say that trauma, especially like past trauma, is like a string of pearls. And so you pull on one string on the top pearl and everything comes with it. So somebody that's sitting in a hospital bed and they are grieving their poor health, I can tell you all of those string of pearls, in 20 minutes, they're going to open up to me about their mom who passed away, their child who died when they were 7 years old, this other grief and the grief is just right here for them. And they don't know what to do. They haven't even thought about those losses in 20 years, but all of a sudden they have a personal loss of something that's bringing them into hospital. And all of this past is just coming like a tidal wave up on them. And they've lost their sense of meaning, their sense of purpose with it. They don't know if they have this past grief and what to do with it. I can help them sort through that and also bring them into the center, bring them into the present. And that's where I would contain it more for them. If it's not appropriate, hey, we can acknowledge and notice that pain of your 7-year-old who died. Tell me about your 7-year-old. I'm not going to go into a long-term grief counseling for that 7-year-old, but I'll help bring them back into the present of experiencing their grief in their bodies safely. And then the last one is ethical dilemmas. Again, it sounds weird to say, but I love getting brought in for ethical dilemmas because a lot of the time ethics actually come down to these pieces of what is really important for you. And it's gray area. We can't say everybody should do this. Classic is assisted death. We would never say everybody that has ALS should automatically have assisted death. That is so unethical to even suggest that. And nor would medicine even suggest that. But what we want to do with an ethical dilemma is saying, why would this be a personal choice for you or not? And so everything I've said prior to about spiritual health, of how we come in to address sense of meaning, sense of purpose, sense of agency, can come in to help address these ethical dilemmas. Do I want a longer life with less quality? Or do I want to have a really good quality for a shorter amount of time that remains before me? And you can give me all of the medical jargon, and I want all of that medical info on it. The patient might be thinking, but then I have to make this decision. Do I want to extend my life as a palliative patient, or do I want more quality of life? And I know what you can ask me. You can ask Dr. Woodley about the chemo that I might do to extend my life. But at the end of the day, do I want to do this for me? And that's where we can come in to unpack some of those things for that person of, tell me about your family. Tell me about your circumstances. Tell me about your values and what are your goals of care right now. Would this be something that would be helpful for you or not? A really big area that I come in with is when somebody is considering an assisted death. And there's a big difference between saying, yes, you qualify for track 1 MAID and having actually a medical assessment. I don't do that. I'm not a doctor. Only doctors can give the medical assessment. But do they want an assisted death? Does this align with their goals and their values? And that's a conversation that takes time. It takes time to unpack. It takes time to build that rapport. And a really good doctor, and I think all of our doctors do a really good job of trying to make space for that, but doctors also aren't trained in existential therapies or emotionally focused therapies. That's where my training can come in and say, okay, we know that you can qualify medically for it. Do you actually want to have this provision? They'll talk to me about, I don't know if I can tell my kids that I'm going to do this. How do I tell my wife or my spouse that I'm considering doing this? And again, that's that role of that intimate stranger, if I could put it that way, where they can safely explore that. And they can say anything they want to me because I'm not their wife, I'm not their doctor, I'm not their kids. And I have that safety to contain the mysteries of their own soul, their mysteries of their own life, and what's really important and valuable for them. And help them ultimately move through that ethical dilemma. I've often seen, and sometimes it's honoring the patient's choice regardless. Of course, I have my own bias. I would love people to have open communication, but ultimately I have walked with patients that have chosen an assisted death and chosen not to tell their children about it. They walked through that exploration. They felt really confident at the end with their choice, and I honor that choice and help them move through their provision with their own dignity and their own sense of personhood. And that sometimes is maybe bracketing some personal ethics of, I'd love you to be able to tell your kids and you can have all of this, but like, I don't know all the stories that have gone on for their family history and that's leading them to this decision. But I feel confident that I was able to explore with them their fears, their emotions, their hopes, their decision-making process, and they've arrived at their decision and their conclusion, and how can I honor their dignity and walk with them through whatever decision it is that they make. Tied to all four of these is just the emotional aspect of end-of-life care, existential care, emergencies, and ethical dilemmas have a huge emotional component of what's going on for me and how I'm feeling. And if I can actually help the patient be able to verbalize and express their feelings safely, that is the scientifically proven key to help them move from this place of angst and indecision to being able to experience their grief, their trauma, their whatever it is, and come back to a place of consolation, coming to a place of I'm once again finding my sense of self, finding that I am human. I'm not just a patient. I have this value. I have my agency, my ability to recover and make decisions. Okay, so let me tell you a couple of stories before we go into questions. They're about all of these different ones. And I've given you a couple stories already, but let me tell you one particularly when it comes to existential pain. There was a patient that we saw, some of you actually here in the room might have seen her too, last year. I'll call her Jenny. And she was from Port Alberni and she was transferred here. She had compartment syndrome from addiction. Unfortunately, she was down for 6 hours. I think it was on cocaine, and transferred to the ICU in Nanaimo, and unfortunately had to have an amputation of her leg. And when she was stable enough to come back here, there was the long recovery process. So I wasn't there in her ICU admission because I practiced here, not in Nanaimo, but the spiritual health practitioner had worked a little bit with her in some of that containment and recognition. But she had so much loss of self and loss of personhood. And like, no guff, I would too. I've just lost my leg. And she needed to work through all of those pieces of, who am I now? I want to recover from this addiction. And she would say to me, I have only to look down and see that I don't have a leg to remember that I never want to do cocaine again. But also finding that agency of, why was I addicted to cocaine? What were the deeper issues going on for me that I needed to numb some sort of deep pains? And there was deep childhood pains that came out in that in our long-term counseling sessions. She also had like trauma recovery that she needed to work through. I remember her saying to me, I was in the ICU and I don't even know, I think they said it was about day 10, and she said, I only remember this woman who was a nurse saying to me, you don't have a leg anymore. That was her memory of being told that she had experienced amputation. And there was a lot also that was missing in her memory. It's very common for patients that are out of ICU of like trying to put the pieces back together of what even happened. She had a lot of issues to work through with feeling of abandonment of a spouse who was in the house for those 6 hours. Where was the spouse when she was lying on the floor over her leg? A lot of issues to work through there. She struggled with living under the diagnosis of a quite debilitating mental illness, working through her sense of agency and loss of self with that. And I saw her that whole time through, all the way through rehab and then to discharge. She came and saw me a couple times as an outpatient. She had to get, for one admission back, had a bit of problem, I don't remember what was going on, something septic with her amputee, with her stump, and I went and saw her even in the hospital then when she was there. But she was able to regain that agency, and I'm actually proud to say, so far this woman is experiencing an addiction-free life now, back in the community. And I credit that to the consistency of the team here, of rehab, seeing her day in and day out, cheering her on, being able to talk about her emotional issues, her loss of self, and then reauthoring her life to be, I still am a person. I still have my human dignity, even though I don't have a leg, and I can recover from this addiction. I don't know if we have time for any more stories than that. I want to end though, before I kind of come into some question times of what makes us unique, I suppose. Because in some ways we are a little bit of the unicorn of the hospital. I think because we deal with such non-medical, non-psychiatric, in many ways non-task oriented work. So if I come into structured team report and I'll get a button, and like there's lots of people that I'll hear in our framework, we have the ability to be proactive and self-refer to people. It's like, oh, there's obviously something going on for there. I can check in with that person. But a lot of the times our when we're consulted, it's not necessarily for, well, we can't sign off and get this person discharged unless spiritual health sees them. Because these existential issues are ongoing, right? And if it's great, I would love it if I could see every single person in hospital, but I try to limit my consults to be ones that really are timely for that person. And sometimes it actually does matter, especially if it's ethical dilemmas of they have this roadblock, they don't want to do this, and they need this medical procedure, but we need to explore what the emotional roadblock is. And if we can clear that emotional roadblock, it actually may help with their discharge planning. That's one of the areas that makes us unique. Sometimes I'll come in when I'm building rapport with patients and I'll say, I'm the only one in the hospital that's come in without a needle or a diagnosis or a test. I'm just here for you. And they're like, come in. They love that. That's something that makes us unique though, in the sense of, yes, we can have tasks. I can go through an actual spiritual health assessment, or I can go through a questionnaire of their goals of care, but it's in a very person-centered, very down-to-earth way that makes them feel seen and heard and valued, and that their story matters. The last thing that makes us unique is we're here for staff too. It's part of the Ministry of BC's Framework of Health for Spiritual Health has put us in as the counselor for staff. So it's one of your options. If you are feeling overwhelmed, you have so many options. You can call the EFAP and speak to a counselor. We have good benefits that we can go and see a paid registered clinical counselor, but sometimes people just want to talk to me for 5 minutes to just let off a bit of steam. And also the sense of, I'm in the trenches with you. That's where, like, coming all the way back to, we're not chaplains at all, not that religious hat, but I love that image of the padre, the chaplain in the military, that is right with them, but the military chaplain is there for the moral support of the other soldiers. And their officers in the army, they go do basic training, they wear the uniforms, but they don't bear arms. So that's similar to me in the sense of, I don't have any needles, I don't do anything medical, but I'm in it with you. I know what it's like to be in the trenches. And sometimes people just love to be able to access me for that, of saying, you also were in that, even that code that we did today, or that family meeting where, you know, a patient or a family member just took a slice off of our colleague, and I'm struggling with that. You can come and talk to me about that. I do supportive counseling for staff, trauma recovery of their own psychological impact of consistent exposure to the trauma of others. It's called vicarious trauma. And we have special training in all of those areas. If you have experiencing compassion fatigue, where you're just getting burnt out from giving compassionate, empathetic care time and time again, day in and day out. Or you have a sense of moral injury, we're working in a system that has a lot of holes, and you know, we're in a time where we're not prioritizing healthcare like we could be, as a country, as a world entire. And that's hard to work in, to feel like I'm part of a system that's broken, and it can create a lot of a sense of moral injury of, am I perpetuating this wrong by working in this system? Or moral distress. That's a large piece that comes up if I saw something that I felt was an unethical decision and it's really triggering for me, and I don't know if I can keep coming back in to work. I need to work through my moral distress. You can come and talk to me about those. And it's confidential. I'm a vault. And I also like that, again, within the framework, we're managed not by, like, my manager isn't here. We're program managed. So that is intentional, that we have that sense of confidentiality of, we both don't report to Jean or the same manager. You can just come and talk to me about your own emotional issues or interpersonal relationships of things that are going on in your home life that are affecting you here. And It can be 5 minutes. Sometimes nurses, various people in the hospital will give me a call on their day off and say, I need to talk to you. And it's a confidential vault. There's obviously no medical record keeping of that because you're not patients, you're colleagues in that sense. But it's a beautiful part of our care that comprises about 25% of what I do is just giving staff care. So that's also a service that's available. So if somebody's struggling, with things, you'd be like, hey, you can go talk to Lydia about that. And they can. And it's held in the strictest confidentiality. And I loved giving that service for our staff here as well. How to get a hold of me for consults. You can consult me in Structured Team Report. You can send me an email. I'm around every day. Just say, oh, hey, can you go see Joe in 2804? Like, whatever. You can give me a call on my local 41424. You can pull me into ethical dilemmas or family meetings if you need. Sometimes for those, I don't go in if I feel like I might threaten the therapeutic relationship I've built with the patient themselves. I won't go, but sometimes I will go if it actually helps the patient feel like they can find their voice to say what they want and need. Again, it's very patient-centered, person-centered of what's the best thing for the patient in this situation. That's all I'm going to say. I think I've talked for 20 minutes.
You did a really good job explaining it.
Oh, thank you.
Yeah, very good job. Yeah.
That's great.
Yeah, you broke it right down.
Good. Thanks for doing these videos.
Oh, you're welcome.